A.
Well, it's a pleasure to be here, and usually I do a fair amount of speaking back in the United States, and I'm from Atlanta, where I practice and run an entire medical center. And depending on the size of the crowd, I find myself dissociating and just going on autopilot. Luckily, I do a fairly good job most of the time, and then I re-enter my body after the talk is over. But since my talk today is about mindfulness, I'm going to attempt not to do that. And I'm going to attempt to savor and be mindful in this moment. So, I have a question for you, which is, do we have any U2 fans in the audience? Okay. A little bit odd to start my presentation this way, but there's an old U2 song that starts with, "This is not a rebel song. This song is Sunday, Bloody Sunday." And I feel like I have to say, this is not a this is not a deep dive into the medical science of mindfulness today, with only 30 minutes or so. What I really want to do is help us understand how we leverage mindfulness in our practice as naturopathic physicians. So we will go into some of the clinical science, but at the end, if I've done my job correctly, you will leave here highly motivated to make mindfulness a little bit more, or a lot more, of a priority in our practices. Okay. Now, we know that we live in a very stressful culture, almost no matter where we live. In America, I'm not sure, but it seems almost worse of any place in the industrialized world. We experience stress essentially all the time. Okay? And it's not going away, and it affects us. It affects our sisters, our wives, our mothers. It affects our husbands, our dads, our brothers. It affects our children, our grandchildren, our parents, our grandparents. These are our patients. These are the people that come to us in search of help for their physical ailments, sometimes mental ailments, sometimes whole body ailments. But my posit here today is that as naturopathic physicians, we are uniquely positioned to intervene, to assess, to monitor, to track, and to rebuild our patients' resilience because of our unique approach and perspective on the biology of resilience, on the biology and really the science of hope, the biology of stress, which I'm going to talk about, and the science of hope, and even just the general sense of hope that we bring to our patients who are looking for alternative perspectives. In 2003, there were about 52 research publications on mindfulness research. Fast forward 10 years, and to 2013, there were about 549 research publications in just a decade. So there really has been a revolution, not just in the medical literature, but as we know, in mainstream and in pop culture. So I have another question for you. How many of you, and let's just come back into your own bodies right now, how many of you, raise your hand, can say that you talk to your patients and help them implement mindfulness into their lives? Raise your hands. Be proud. Show your neighbors. Have fun. Okay, hands down. Now, I'm going to ask the question a slightly different way. How many of you can claim that your patients, all of your patients, are successfully implementing mindfulness every day?
No one.
Aha, I thought I might get that response. Many, many less hands. But how do you think they would feel and respond if we were to make a a little bit better push in their lives with mindfulness? Do you think they would be healthier, recover faster, maintain that recovery, prevent disease and other problems in their life, handle the stresses of life, not just on their health, but in all of their life better? How would you feel if you were part of that process? How would your practice benefit? How would your everyday care benefit? Would you be practicing with more drain at the end of the day, or with more uplifting sense of spirit at the end of your day? Would you be practicing more dis-ease management, or would you be practicing more ease management? How do we do it? So here I told you we would talk a little bit of science. And to be honest, with an international audience like this, I really don't know how much each of you go deep on the science. For instance, today we will just do a very, very brief refresher on the HPA axis. Some of our earlier speakers touched on this. Just a gentle reminder, this is the body's stress axis. This is the HPA, hypothalamic pituitary adrenal axis. It's our stress axis. As our hypothalamus senses all conditions of stress, it produces CRH, which talks to our pituitary, releasing ACTH, which travels to our adrenals, causing glucocorticoid signaling and release of glucocorticoids like cortisol. Today, our understanding of the HPA axis is such that it affects nearly every physiologic and metabolic function of nearly every cell, and affects HPA axis function or dysfunction is at the heart of so many, almost all, medical conditions. Here's one thing that you must keep in mind when we're talking about activation of the HPA axis: stress, correct? Except in discussions with patients, you have to slow down and make one thing very, very crystal clear, because patients think of their stress as psychological stress, mental stress, emotional stress. Now, we all know in this room that metabolic endotoxemia, thank you. I said it again. Metabolic endotoxemia is a huge stress factor. Food sensitivities are a stress factor. Gut-brain dysfunction, gut-brain axis dysfunction is a stress factor. Molds, environmental toxins, heavy metals, sleep deprivation, pain, inflammation, chronic autoimmune disease, all of these, dysglycemia, these are all stressors. Our patients don't realize this. They need to realize that they're under tremendous amounts of stress from many different angles, and that it's affecting, very likely, their HPA axis. So how do we benchmark stress? 3 ways that I'm going to share with you today. And one, I don't want to insult anyone's intelligence, but it first starts with talking to our patients, asking them about their stressors, where they're coming from, how they're managing them, what kind of support they have, writing it down, remembering, digging through it, and having that discussion every time that you meet with them. But we have to build on that by the use of validated psychiatric scales. These are easy to use. And what they do is help quantitate and monitor and track progress. Subjectively, they are self-reported, but objectively, they do allow for some quantitation and some tracking and some measurement. And not for nothing, when patients are a little bit behind in seeing their own clinical progress, when you can show them their Hamilton depression score went from 37 to 7 over a 3-month period, it does help your case and helps them understand that they actually are showing signs of improvement. So we have things like the PSS, the Perceived Stress Scale, Hamilton Depression Scale, Hamilton Anxiety Scale. There's many more scales. These are the ones I like and use routinely in my practice. And then, of course, we have laboratory data. And when it comes to laboratory data, this allows us to peek inside the HPA axis, as well as causative factors, causative stress factors that will influence HPA axis function. So we're talking about inflammation, nutritional status, hormonal balance. Inflammatory-wise, these are things we're probably all doing and can be doing, measuring and looking at for food intolerances or food sensitivities, looking at CRP in our patient's blood, looking at omega-3 index. Nutritionally, we're looking at lots of things, but specifically vitamin D and homocysteine and B vitamin status, ferritin and iron, low iron or iron excess. But these are all nutrients that directly impact our HPA axis and the ability of our nervous system and our neurons to even manufacture neurotransmitters. And then, of course, we have the interaction between the endocrine system and the HPA axis, and we must look at what's happening deeply and robustly at thyroid hormones and glycemic hormones and sex hormones. Now, I was going to say I'm not going to go deep into the human microbiome. Our previous two presenters have done a very, very good job at that, but it is without any hesitation that we know the human microbiome influences the HPA axis. 2 weeks ago, I gave another lecture, which I thought would have fit in really well with our first presenter's talk about oxytocin, and oxytocin influencing the microbiome, and very likely through circulation and through the vagus nerve, actually causing increased production of oxytocinergic neurons in the posterior pituitary, which then obviously, with oxytocin having a positive impact, down-regulates HPA axis function. So very fascinating, but I'm going to leave those topics to the other presenters and move forward on how do we look at HPA axis function. It's clinically available, at least in the United States, and I do know in the United Kingdom. I'm not sure internationally, but we're talking about essentially just looking at adrenal hormones, 4 timed cortisol specimens to capture the circadian rhythm of cortisol, plus 2 average DHEA levels, and a morning urine specimen. So easy to collect, non-invasive, and neurotransmitter levels allow us to look at inhibitory and excitatory neurotransmitters, GABA, serotonin on the inhibitory side, and glutamate, dopamine, norepinephrine, epinephrine on the more excitatory side, so we can see overproduction, underproduction, or imbalanced production. But what this really allows for is for us to look at each individual patient's response to their stressors, now, months ago, and likely years ago, and the chronic impact that that's had, or the long-term impact that's had, so that customized therapeutic decisions can be made. So, Hans Selye coined the general adaptation syndrome, but this is, as we look at what you might expect context-wise, you're really looking for categorizing the patient more for them than for you sometimes, because you need real data. But from a conceptual standpoint, we're looking at, is this an early or alarm stage, a middle or resistance stage, or a late long-term effects of stress and a more exhaustion stage? This is sort of the conversation you would be having with patients to help them understand the long-term impact of their stressors and what it's done on their ability to respond to stress. This is just a simple example of what a data set might look like as you gain information about neurotransmitter production and cortisol secretion and DHEA secretion. Just a quick bit of helpful tips for anyone that might glean anything from this, but we're really, when we're looking at the circadian pattern of cortisol, yes, we're looking for overproduction, we're looking for underproduction, and we really are looking for the timing of production as well. The actual circadian pattern itself is a validated biomarker in the literature. Morning cortisol is a validated biomarker for the assessment of risk for depression, but the actual circadian pattern is known to be a biomarker. So we're looking at the whole thing, the diurnal pattern, overproduction, underproduction, morning cortisol. If there are any unique blips, I call them, on the screen, everything looks good except at 4 p.m. there's a giant cortisol peak, then you would ask questions. What happened at that time? Did you skip a meal? Was it low blood sugar causing a cortisol response? Did you have a migraine headache? Did you go and exercise and run 3 miles with medium intensity at 3 o'clock in the middle of the afternoon before you did your collection? You have to weed through and understand what those blips may be looking for or maybe telling you, as well as looking at ratios like norepi to epi, which is a very good fatigue and burnout marker, and cortisol to DHEA ratios as well. this concept of HPA axis dysfunction I like to talk about because, as we all know in this room, traditional ways of diagnosing and labeling our patients' conditions doesn't really help very much in terms of it really ends up being a simple label of a set of symptoms or constellation of symptoms. And the research literature has categorized different Westernly diagnosed or Westernly labeled conditions as having been associated with either known increases in HPA axis function or known decreases in HPA axis function or dysfunction or decreased activity overall. And I'm showing this to you just so you understand, yes, we want to understand the diagnostic training and methods and labels that we were taught in medical school, but we, as functional medicine providers, as naturopathic medical providers, we want to dig onto the actual physiological causes of the problem. And looking at HPA axis function can help us do that more than simply labeling them as chronic fatigue syndrome or something similar. I want to touch on neurogenomics, and the first gene that you might think of that I would possibly mention might be MTHFR, but you would be incorrect. I'm going to talk about a different gene, the SERT gene, the serotonin transporter gene. And I want to talk about this gene because it goes to specifically a genomic predisposition to stress sensitivity. So this gene is a gene that codes for the protein that sits at the cellular membrane of the presynaptic serotonergic neuron. So it shunts serotonin through the cell membrane into the synaptic cleft, where it has the opportunity to bind with the postsynaptic neuron, thereby completing the cycle of serotonergic neurotransmission. So what they found is that there are polymorphisms that, again, this is a gene in the United States anyway that is clinically available and clinically actionable, and I'll tell you about what I mean there in 1 second. Polymorphisms in this gene are associated with a shorter or S allele that convey an increased risk for HPA axis dysfunction, lower stress sensitivity, and actually this is the site of the mechanism of action for where a lot of SSRI medications exert their impact. So if you have patients with a polymorphism in this gene, which you can measure, they will not be good candidates for SSRI medications, and they will not respond well, and they would be more prone to adverse side effects. But really where I use this information is to show patients that they are not flawed. They are not weak. This is not a personality deficit on their part, that they don't handle stress well, and that they may have developed a mental illness. It's to help them understand genetically that they've been vulnerable and how they have some of the other stress factors that have landed them in the office, so that I can empower them and educate them that therapies like our naturopathic therapies, including mindfulness therapies, really in their lives and in their treatment regime now become essentially a non-negotiable, but they understand why. What do we do with all of this information? We're using it. We're using it to customize prescriptions for our patients, to help coach them or advise them on existing medications, which ones they may do better with or not better with, customize supplements, and really look at ways that we can offset and prevent future problems before the onset of symptoms occur because of this inroad and this look at their genomic future and their HPA axis and all of the other laboratory data that we've been talking about and looking at. And like I said, it brings the conversation back to what's happening in the real world. Diabetics who are insulin dependent have to take insulin. They usually don't really sit there and every day, 3 times a day, or however many times they're doing it, beat themselves up about it. People with chronic sinus infections, we probably counsel many of them about nasal irrigation to improve the tone and strength of their sinus tissues. And I have the same conversation about my patients about mindfulness. Yes, you're one of those. Just like a diabetic or someone with chronic sinusitis, you're the lucky one that just has to prioritize mindfulness in your life. Something happens for them. The light bulb does go off. They finally get it, that this becomes really a very important key to their resolution of their health concerns, as well as prevention of others. So we really let data drive our decisions as clinicians. Really helps us, again, personalize and customize what we're doing for our patients, but it really helps drive patient motivation and patient buy-in and patient cooperation when we mix all of this essentially together. As naturopaths, we're always leading with lifestyle. We're always leading with diet, I'm sure. Movement, yoga would be perfect in this context. Talking to our patients about sleep and quality and restful sleep, enough sleep, social connection, the power of music therapy, all sorts of therapy, targeted nutritional support based on HP axis function and other markers we might be doing, and, again, mindfulness training. Everyone knows, even lay people without much either cultural, religious, or medical training know that if they were to practice meditation or mindfulness, they're going to experience positive changes, more patience, more compassion, more focus and better productivity, heightened, improved sense of body awareness, less overall stress and anxiety. But we all know, and you can correct me if I'm wrong, that we can talk about mindfulness with our patients one-on-one until we're blue in the face. And there are real-world barriers that we confront on the clinical side, on our side as clinicians, and on the patient side. On the clinician side, it may be lack of training or education on weaving in HP axis assessment and correction. The cost of that, the cost of training on that, the time involved in weaving in a new test and new explaining and new treatments. How do we know which patients we really need to select and prioritize for this type of approach? We may not have much in the way of personal experience. We may not have ever been taught or gone through training ourselves on mindfulness or teaching or implementing mindfulness. On the patient side, it's things I've alluded to. Most patients don't understand the medical benefits of mindfulness. So it's our job to educate them on that. They believe that there's not enough time, and that could not be further from the actual truth, because everyone has 10 minutes. Everyone. Leaders of the free world and maybe even the non-free world have 10 minutes in their day. And medical neuroscience has told us that 10 minutes is enough to change our brains. But they believe they don't have enough time. They also believe that they're not doing it right. They've meditated 2 times and they weren't able to shut off their brain. And they think, well, this isn't for me. I'm not doing it right. I'm not doing it good enough. So that's a big barrier as well. Again, and some people just have either cultural or religious preconceptions or barriers. But in my practice anyway, I'm not really addressing that. I'm addressing the medical benefits and how we can help overcome them. So we have to understand all of these barriers and work hard to overcome them. We know this therapy, this mindfulness training, mindfulness-based stress reduction helps so many. It helps students. It helps adolescents who are just dealing with the stresses of adolescence, never mind school, where things are heightened, seemingly today more than ever before. It's helping our military and our soldiers recover from the stresses and traumas of battle and combat. It's helpful for end-of-life care and end-of-life transitions. It's helpful in the context of patients who are suffering from mental illness as well as physical illness. It's helping us as clinicians with burnout and compassion fatigue and other types of fatigue so that we can still be there and function well for our patients. And as Wimbledon starts here in London on Monday officially, Roger Federer has been very open about his use of mindfulness and meditation to get to the top of the tennis field, and to not only get to the top, but stay at the top. So use of mindfulness, even in highly competitive, highly professional athletes, is associated with improved athletic performance. How do we do it? Well, there's lots and lots of ways to skin this cat regarding mindfulness. There's gadgets. So we're sort of a technological world these days, so I like gadgets. I don't use gadgets with all of my patients, but I at least educate them about them. This is Muse. This is headgear that really is using EEG sensors and with an app, I believe, to your phone that's essentially giving you real-time biofeedback on the quality of your meditation and prompts to help direct the quality of your meditation and mindfulness sessions. Then there's Think headbands, which use a different technology, transcranial electrical stimulation or neuromodulation, again providing real-time biofeedback on your sessions. And the Spire stone, this is interesting, it clips onto your waistline, and it measures respiration rate and patterns, and then through Bluetooth technology, your phone is giving you prompts throughout the day. I've just noticed you had 7 minutes of very tensed breathing, Dr. Bongiovanni. It's time to take a break. So I actually have one of these. I'm testing it out right now. Not right this second, but these days. A Fitbit can be helpful to help track mindfulness minutes and breathing patterns and such. And then this one I also like, which is Inner Balance, which relates back to heart rate variability. It's a pulsometer that clips onto your ear and then into your phone and directs you through different breathing exercises designed to bring you and track your progress to bring you improved heart rate variability. So these are just a sample of the gadgets that we have. And of course, there's just regular old apps. There's hundreds and hundreds of apps in our app stores on mindfulness and meditation. Many of them are free, and the ones that are not free are very, very affordable. Things like Headspace, Calm, Omvana, Buddhify, Smiling Mind, and literally tens, if not hundreds more that are available and literally at our patients' fingertips. I love the apps because everybody has a phone, and everybody usually has an app store on their phone, and the apps guide them from literally start as a novice to what it is and how to do it and how to breathe and how to relax. So you as the clinician can really sort of hand that off to the patient if you're not ready to teach them yourselves or hold classes in your office yourself. Back to, everyone probably knows who this is if you're a sports fan anyway. This is Rory McIlroy. Professional golfer. And this is just a nice quote from him telling us that he uses music to help him relax. And there's actually data that tells us that music therapy lowers salivary cortisol levels and is used to reduce pre-competition stress, and actually also, as a bonus, improves athletic performance. So as I conclude here, the medical science is very clear, and it continues to unravel our brain's ability to adapt and to rewire. And it's this neuroplasticity that really shows us the brain should really be exercised, like a muscle at the gym. And that's how I talk to patients about it. To strengthen our nervous system, not just our brain, our entire nervous system, and all of its tendrils into the rest of our body, to improve our patients' mental and physical health. And a reminder to simply view mindfulness as another of the latest trends or fads in the self-help sort of area of our world is really to undermine its potency, its power, its medical healing powers, its anti-inflammatory effects, and misses the point on why it's gaining rapid momentum, and even in the mainstream and, of course, in our patients. The eminent condition of our age seems to be distraction and easily being distractible or distractibility. So it would sort of make sense that the logical antidote to this preeminent condition would be mindfulness. We know mindfulness reduces cortisol, lowers blood pressure, improves immune function, has positive effects on gene expression. And a reminder that our HPA axis, looking at the stress factors we know activate this HPA axis, modulating that HPA axis in our patients holds a key to unlock and an inroad into treating every patient's condition, nearly every patient's condition. As we know, HPA axis and glucocorticoid signaling affects the physiology and function of nearly every cell. Profound benefits can be realized as we learn how to tap into this HPA axis function and or dysfunction, assess it, monitor it, track it, rebuild it. I call it putting back the tread back on the tire that's been showing all of this wear and tear that we can show our patients. And it really allows us to arrive back at the core of naturopathic medicine. Implementing mindfulness. First, do no harm, primum non nocere, so that we really can improve the health and the life of all of our patients. Thank you.